Tinnitus, someone coming with buzzing feeling or buzzing sounds in the ear. Can be objective. Objective start with O, others start with O. So objective, others can hear. Tinnitus. Subjective, only patient can hear. S, solo, so only patient can hear. Tinnitus, when he started to have the sound or buzzing sound in the ears. Can you please describe it for me? Is it all the time or it comes and goes? Is it in one ear or it is both sides? Okay. Does that ringing match with your heartbeats? Is it worse at a certain time, especially when you put your head on the pillows or at night? Any hearing problem, any vertigo, dizziness, any ear fullness, Meniere's disease, any balance problem, any pain in your jaw, okay? Any other symptoms, any facial weakness, any facial numbness, any headache or visual change, all of that, okay? And does anything make it worse, anything make it better? You can ask about this as well. Impact on sleep, impact on daily life, impact on the mood is very important. Why? Because if there is any significant stress, you need to refer this patient. Tinnitus is very common, by the way. And you may have many cases. I had many people in the GP practice coming with tinnitus. And usually we do nothing if there is no any other features or any other symptom, no hearing loss, no all of that. They don't have any anemia and they don't have any high blood pressure, all of this. Okay, so and make sure also there is no any noisy environment. How to explain? Tinnitus is when you hear sounds like ringing, buzzing, hissing that doesn't come from outside your body. Usually it is inside your body. Your sounds are in your ears or head, and only you can hear them. Usually it is caused by something affecting your hearing, like being around a loud noise, sometimes ear infections, or sometimes as a part of getting older. Most of the time, tinnitus is not serious, and it can get better on its own. But for some people, it can be problematic or give them some symptoms or affect their life, affecting their sleep, their concentration, and their mood. Management, addressing the eyes, diagnosis, give options. There are many options for tinnitus: face-to-face, referral, safety net. Options, what patient can do, what we can do. We'll come to this. Face-to-face, definitely we need to examine the ears, check your hearing by using the tuning fork, examine your head and neck, and do some neurological examination. Also need to check your blood pressure, listen to your heart. Okay, medication review, very important, very important. Okay, here, if you can see in the questions, any recent medications, please go through all the medications that the patient can take. You will be surprised from the list of the medication that can cause tinnitus. And you may have a patient in the exam coming with tinnitus, he is on one of those medications. So you might need to go through all the medications, because if there is any medication that can induce tinnitus, one of the management options, you need to review the medication by stopping this medication and see if that will help you. Then refer to audiology. Refer them to audiology. Okay, to check their hearing, to make sure hearing is okay. And then discuss with the employer if applicable. For example, if it's in a noisy environment or working with the heavy machines, all of this can be part, or tinnitus can come as a result of this, being in a noisy environment. To speak to your employer, maybe amend the duties, maybe occupational health to review him as well, especially it happened because of the working in a noisy environment. Hearing protection, okay, self-help measures, hearing protections, soft background noise or white noise, like fans when sleeping or when symptoms bothering you. Safety net him if any new symptoms, if any hearing loss needs to come back, and signpost him to PTA. Okay. I think PTA is British Tinnitus Association. Then medications that can cause tinnitus. As you can see here, many medications. Ibuprofen, if he's taking over-the-counter medication for his knee pain or arthritis, or aspirin or naproxen. Usually, tinnitus with these medications reversible when we stop the medication. Loop diuretics. How many patients we give them diuretics in the GP practice? Many. Use can cause tinnitus and is reversible when we stop. Aminoglycoside antibiotic, unfortunately, can be permanent, not reversible. Chemotherapy, unfortunately, can be permanent. Some anti-malarials like quinine, chloroquine, reversible. Antidepressant. How many patients in the GP practice they take antidepressant? Many, many. So medication review is very important, and we always tell you guys in the exam, even people who comes for our mocks, you will find. Okay, I will tell you guys if someone attended the mock before or someone is planning. You will always find in one of our mocks a medication review part is very important to be done in one case at least. What does that mean? You need to go for the past medical history and you cross and match the past medical history with the medication list that the patient is taking. Okay? So cross and match is very important. Cross and match past medical history with the current medication that the patient is taking. You will be surprised from the cross and match result. You will find sometimes they are not taking necessarily medications they need to take. They are taking unnecessary medication that they need to stop, and so on. Or they are taking not the full dose from two medications. So you need to stop one and give them full dose from another medication to reduce the polypharmacy. Okay. What patient can do? Okay, often it goes by itself. So reassure. Sound therapy, noise background. Avoid the triggers. Avoid the trigger. Avoid being in a loud environment, noisy environment. Stress. Stimulants like caffeine and alcohol sometimes can worsen. CBT if it is affecting his mood. Okay. Hearing protections as well can be one of the options. And resources: PTA, British Tinnitus Association, or Action on Hearing Loss, or Tinnitus UK. Resources to signpost your patient to for more information about tinnitus, different causes of tinnitus, different management options, self-help measures, and when he should seek urgent medical advice. Again, this is something that you can tell in any signposting. Okay, charity, you will find out more about your condition, different causes, different treatment options when you should seek urgent medical advice. What we can do, medication review is very important. Medication review, one of the treatment options. We can stop your medication for some time and review after a few weeks to see if it did help to improve your tinnitus or not. If not, so we can investigate further to see what else can be the cause. Treating underlying cause, for example, impacted earwax, any ear infection, all of this. Referral, refer the patient to audiology for sound therapy or tinnitus retraining therapy, which involve masking sounds, desensitization technique, all of that. So we refer the patient with tinnitus to the audiology team. Psychological therapy, if it is affecting his mood, affecting his not coping with this, causing for him some significant stress, CBT, and mental health support. And resources, as we mentioned, PTA. Then I'll put for you guys this table just for you. Again, it is from the AKT course. This table from the AKT course. But if you would like to read, you can read. If you don't, just skip it. Okay? It's just objective tinnitus. If you have someone with objective tinnitus, what does that mean? You put your ear beside the patient. You put your ear beside the patient ear, and as a doctor, you hear. Objective, others can hear. Refer him to anything. It could be some vascular causes, okay, that needs attention and more investigation, or sometimes muscle-related causes. Subjective tinnitus, only the patient can hear. If it is unilateral with sensory neural hearing loss, so we can think about Meniere's acoustic neuroma. If it is bilateral with sensory neural hearing loss, so we can think about noise-induced hearing loss, drug-induced age-related hearing loss. If it is subjective tinnitus with conductive hearing loss, so we can think about sclerosis or middle or outer ear problem. For example, impacted wax, otitis media, cholesteatoma, below ear, all of this. Okay, so for me, this table is really good. Why? It will put a map in your head. Is your patient coming with unilateral with sensory neural hearing loss, bilateral with sensory neural? So you think about noise-induced, medication-induced, age-related, or some like conductive hearing loss element. So if it's conductive, could be your ear, impacted wax, otosclerosis, especially if there's any family history with tinnitus, all of this. So I like this table, okay, because it narrow differentials to me. Even in the practice, I usually open, by the way, because I have access to the website, I open this to find, because I don't want to miss anything from this. Okay, so this is very important to also put some differentials in your mind. Tinnitus is important because you will have some patients with tinnitus. Then referral criteria, guys. Referral criteria. Immediate referral within hours if your patient is at high risk of suicide because of severe mental distress from the tinnitus. So this patient, because he is high risk, refer to mental health crisis team if he is suicidal because of tinnitus. And believe me, sometimes tinnitus is really very bad, affecting the patient's mood, causing significant stress. They can't sleep at all. They can't function. Severe loud noise in both ears. Sudden significant neurological symptoms, for example, facial weakness, severe vertigo, they be referred for neurological assessment, so he needs to be referred straight away. If we suspect stroke, definitely straight away, or sudden onset of pulsatile tinnitus or tinnitus after head trauma. Again, straight away, he should be seen within hours. Tinnitus after head trauma or sudden onset of pulsatile tinnitus, refer. Then very urgent within 24 hours, very important here. And please, guys, very, very, very important note, listen carefully. If someone coming with sudden onset of tinnitus with hearing loss in the last 30 days, he needs to be seen within 24 hours. Sensory neural hearing loss is a medical emergency. Urgent within 2 weeks if he has tinnitus, okay, with distressing impact or with like impact on his daily life, causing some distress, we refer within 2 weeks. That's why it's very important to ask about the impact on the patient mood and anxiety, stress, all of that. As we mentioned, if he has sudden onset of tinnitus with sensory neural hearing loss or hearing loss in the last 30 days, he needs to be seen within 24 hours. If it is more than 30 days, he needs to be seen within 2 weeks. Here, sudden within and develop more than 30 days, or rapidly worsening hearing loss, refer to be seen within 2 weeks. If there's any persistent ear pain or chorea, also refer. Routine referral for others. Persistent tinnitus that affecting the patient, tinnitus of unknown cause or causes. Then you will have this. Sudden sensory neural hearing loss is a medical emergency. Why? Because early intervention and early treatment, usually with steroids, it can impact the outcome. That's why it's very important. We mentioned in the treatment table, anyone with tinnitus, face-to-face why? Examining the ear, check the hearing. You need to check the hearing loss, sensory neural or conductive. Sensory neural hearing loss is a medical emergency. Don't forget about this. I hope it is clear, guys, and I hope tinnitus now is becoming an easy topic for you, because you will find people coming to your practice complaining of tinnitus. Here, Tinnitus UK. Tinnitus UK again. British Tinnitus Association.